But what this ecological momentary assessment strategy allows you to start to do is, can you detect when they're having cravings in real time? Carrying around their phone, they got pinged. They get a notice on their phone 3 times, I think it was 3 times a day. And the little, they get a little digital question, did you have any cravings since the last time you were pinged? And if they said yes, they automatically got randomly assigned to either a mindfulness intervention for craving or a distraction intervention, or just thank you for letting us know. And so this EMA allows you to start to assess people more frequently while they're home and in and about in the world.
Welcome to High Five with Dr. Igor Grant, Distinguished Professor of Psychiatry and Director of the Center for Medicinal Cannabis Research at UC San Diego. Each episode will take you on a fascinating journey into the evolving world of medicinal cannabis, as Dr. Grant poses 5 thought-provoking questions to his guest, uncovering their personal journey and unique contributions to the field. Now, here's your host, Dr. Igor Grant.
Today, I'm pleased to welcome a colleague and friend, Dr. Alan Budney. Dr. Budney is a clinical psychologist and professor of psychiatry and biomedical data science at the Geisel School of Medicine at Dartmouth University. Dr. Budney is particularly interested in the development of innovative behavioral treatments for problematic cannabis use, and he is especially interested in the use of digital technologies and social media to develop practical, useful interventions. His work has also concerned ways of improving doctor-patient communication about both medicinal cannabis and recreational cannabis. Alan, thank you for joining the podcast.
Thank you for having me. It's a pleasure to be here.
So my first question is, I know that you have been at the forefront of using digital technologies to improve the reach of any interventions for problematic cannabis use. Some of your work involved the use of mobile contingency management to reduce the frequency and quantity of marijuana use for those who wish to do so. First, can you tell us what is contingency management and how is it spliced into mobile technologies?
Gotcha. All right. Starting with the big question. Contingency management. All right. Well, contingency management, I guess the best way to describe it is it's the application of the principles of reinforcement, which, as most of us know, B.F. Skinner started the investigation down that path, and many behavioral scientists since have contributed to our knowledge about the principles of reinforcement. And so it's, how do you clinically apply the principles of reinforcement to create an intervention that can help people? And mostly you do that through positive reinforcement. At least most of the interventions that have been developed with the contingency management framework have used positive reinforcement. And I'll explain what I mean by that. And let's use the substance use treatment intervention field as an example. So first of all, if you're going to use contingency management, you have to have a clinical target. What are you trying to change? What does the person want to change? With a substance use problem, the primary thing is usually drug use or substance use. And so perhaps you want to reduce or abstain from the drug. So you choose a target. It doesn't have to be abstinence. Other things that have been picked in our field have been attendance at therapy sessions, adherence to your medication, completion of other types of therapeutic goals like your homework assignments with therapy, things like that, going to work, attending self-help groups. So you have to come up with a target. And then you have to come up with a monitoring system. Can you actually measure whether the person is meeting that target? Can you tell for sure that they're not using drugs? Do you know if they went to their therapy session? So you need a monitoring system. And so the target behavior monitoring system, if you have those set, then you can set a goal. Your goal might be not to use cannabis at all. And so the goal would be abstinence. And the way you're going to measure it is you're going to get a urine sample or a saliva sample or some kind of objective biological measure to see whether or not they used cannabis. You might also ask them, but you usually want an objective one. And then the contingency part of it is, if they're actually meeting their goal, positive reinforcement is they get an incentive. So some kind of positive consequence is going to occur once they meet their goal. You detect that they stayed clean. And in the substance use field and really any field, the consequence is usually an incentive or a reward, something tangible. In the substance use field, it's been something with monetary value usually, like a gift card, maybe even a voucher system where you eventually give them cash or let them buy things. But it could also be social reinforcement. It could be you're just providing, or somebody in life's providing something positive each time they meet their goal. And so a contingency management system is all about setting up this target, a monitoring system, and a way to provide incentives. And so it sounds pretty simple, but the things that are really important that we've learned from the principles of reinforcement are that you got to get the right measurement. You have to get the right monitoring system. So how frequently do they have to meet the target, or how frequently do you want to monitor the target? How big of an incentive do you want to give them? How often do you want to give the incentive? And how long does the program need to go on? And so the kind of things that people mess up on or do well on is you got to pick a target that has a good chance of happening. So if somebody, for example, I don't know, smoking cigarettes every day, 3 packs a day, to expect them just to quit on day one could happen, but you might come up with a system where you're trying to give them more time, or they're going to reduce over time. So you're setting a goal that's like a shaping goal where they might only reduce from 30 cigarettes to 20, or from 5 days of cannabis to 3. So you have to think hard about that. It's a goal they could actually have a chance of making. And then, like I said, you have to come up with a monitoring system that you're sure whether or not that they were able to achieve their goal. So you don't want to provide an incentive if they tell you they did it, but they didn't really do it. And that's why you use urine testing in substance use treatment if your goal is drug use. How big of a reward? Well, if you're asking somebody to stop cannabis use and they've been using for 30 years every day, 7 times a day, your reward might need to be pretty big to help motivate. So they may have some motivation, but if you're just going to give them 50 cents, that's not going to do much for most people. So you got to come up with a powerful reward. So I think you probably get what I'm saying. So basically in the substance use world, the last probably 20 to probably 3 years now, because I've been doing it for 30 and people were doing it before me, you come up with some kind of behavior in the treatment system that you want to monitor, that you want to change, and you build one of these incentive systems to make it happen. And in a nutshell, that's contingency management.
So I get that. And if I can recall my past lectures on Skinner and such, often it is intermittent reinforcement, or kind of, it's not that you would reinforce each time necessarily. There's a little uncertainty that's built in.
Yeah, so that's the schedule of reinforcement that I was alluding to.
Yeah.
In the substance use field, particularly the last 20, 30 years where we have been doing most of this work, actually, it makes sense sometimes to start with a fixed schedule. Try to actually reinforce them every time they do it, because it's so hard to get drug use under control. People have a hard time quitting. So in the beginning, you may try to reinforce it as often as you possibly can. Now, logistics make it hard to do it all the time, but reinforcing on a fixed schedule or as often as you can is great. But other people have tried to go with an intermittent schedule. Like you monitor it all the time, but only once in a while do you provide the reinforcement. And those schedules can potentially have more power over time. So people have dabbled with both of those, particularly in the cocaine field. In the cannabis field, back in I guess it was the mid-90s, we started to do this with people that are seeking treatment to reduce their cannabis use or quit. And we did this at about the same time. There was a group from Yale and a group from UConn that had the same idea. And we all ran these studies where we used contingency management, set up an incentive system where the people that came in for treatment into the clinic, usually 2 times a week, and we took urine samples from them each time, and we set up a system. The system we set up was a 12-week program where they got cognitive behavioral counseling, but they also got this incentive system. And the way the incentive system worked for cannabis was over a period of 12 weeks, if every urine test they gave us, 2 a week, was negative, they would earn $570 worth of gift cards. So it seems like a large magnitude. It's not really that large if you think over 3 months what that comes out to per day. It's not that much. But anyway, if you set up a system like that, it can work. And it did work in our program, and it did work in the Yale program, and it did work in the UConn program. And the combination of contingency management and cognitive behavioral therapy worked better than therapy alone, and it worked about the same as contingency management alone during treatment. But having the therapist helped enhance treatment and the effective treatment over the long haul. So if you have a therapist and contingency management, we're getting longer periods of success over time. And that's been replicated in the cannabis field and the cocaine field. And so that's where our contingency management work started in the cannabis field. And then we switched to digital, or started to work in the digital mobile field.
So this is a question I wasn't going to ask, but it just occurs to me. And you mentioned the importance of the therapist also to continue reinforcing that. Could you use an avatar of some kind or artificial therapist? Do you have to have a person?
Good question, because that's where my work went. One, because, getting therapists to do this work is hard and costly. And my colleague, Dr. Lisa Marsh and Dr. Warren Bickel, had started working on a computer-delivered cognitive behavioral or community reinforcement program that greatly reduced the amount of time that the therapist needed to spend with the patient. So the computer actually delivered all the coping skills treatment, all the positive reinforcement system was kind of managed online. The therapist was basically a check-in. And so we set up a study to try to do that with people coming in with cannabis problems that wanted to quit. And so the treatment design was pretty straightforward. Again, contingency management alone, contingency management with a therapist, and then a therapist alone. And pretty much we got the same results. Contingency management and contingency management with the computer did equally well. And the therapist condition did not do so well, or as well.
Well, also, I guess if one uses very advanced AI technologies and such, the computer can be sympathetic and never get impatient.
Well, it could be. Ours was not. This is back in, I guess it was 2000 or so. Ours was pretty much a straightforward computer software program where you just were doing your stuff and reading slides, doing practice exercises. It was nothing fancy. It was just computer delivered treatment with no avatar.
The point is, it might do even better with kind of a much more nuanced approach, right?
Yeah, and that's where people are going now. Those treatments, the ones that are just the computer delivered it, that's digital, but again, not fancy and not mobile because you have to come to your computer, still reduces the cost. You have less cost for a therapist. And it makes it easier for patients to come in for treatment or to do their treatment because the therapist doesn't have to be available all the time. And so there's access increase, there's reduced costs. And so that kind of worked. And so from there, that still required people to come in. And so that's where others started to say, hey, we can program this on a phone. Now that a phone has become a computer, all this stuff that we're doing on the computer can be done on the phone and people can do it anytime they want. Now, the problem with that, if you think about it, the contingency management part, if you're going to measure abstinence or drug use as your primary outcome and have incentives based on that, you need to have a way to do that mobily out in the real world to not make them come into the office. And so that's where people started to get creative things with use of cameras on their phones. I think one of the originators of that was Jesse Dallery did it with cigarette smoking, where his phone could hook up to a breathalyzer, a carbon monoxide tester, whatever you call those things, equalizer. And you could have you could visualize the person blowing into the tube and showing what the results were on a carbon monoxide to see whether they use tobacco or nicotine or not. Now, in the cannabis world, we don't have a breath test that does that. We don't have any great tests. You don't really want to monitor somebody visually urinating and getting urine samples. That was off the table. But colleagues of mine, Gene Beckham and Nate Kimbrell down at Duke and the Durham VA, decided they had a system they could use with saliva testing. So the problem with saliva testing in cannabis is it only really detects recent use. And so usually recent use, if you have the old model of contingency management where you have to come into the office, they'd have to come into the office all the time. But if they're just going to tape themselves given a saliva sample and the test is automated and you see it right away, they could visualize themselves swabbing their cheek, putting it on the little test strip, and then showing the test. And they had people do that twice a day, just like they do for nicotine and tobacco treatment. And so they set up a contingency management system like that mobily on the phone and basically set up a pretty large incentive value and have shown now that that's viable, feasible, and looks like it's efficacious. You can get people to do that, and the saliva testing, if done frequently enough, can be used effectively. Now, others are starting to go down the path of a more sophisticated avatar, more frequent contact with your phone. Your phone can ping you multiple times a day to see how you're doing, to check in with you. I'm sort of involved with one project like that, application called Clear 30 that a fellow named Fred Munch from Rutgers has developed. I mean, it's an app that's currently available. You can go in and download it. It's a business, so I should declare that. I'm on the board, so I probably have some disclosure issues there. But pretty much it's one of these where you can download the app and your avatar, your chatbot, whatever you want to call it. First, you do an assessment on the phone, and then you tell it what your goal is. And then on a daily basis, it can check in with you. You monitor your cannabis use. You plug in whether you use that day or not. It starts to learn what you're doing and checking in to see if you met your goal. And it has coping skills that you can press a module and learn how to relax, learn how to do mindfulness, learn how to practice some relapse prevention strategies, how to say no to your friends when they try to get you to get high, those kind of things. So people are developing those kind of things kind of all the time now, which are kind of cool. There's not great data on any of those and good randomized trials, but they're theoretically strong. They make sense that they should be able to work, and we'll see. Sooner or later, someone will do some really nice work in that area with cannabis.
One thing about all these kind of digital techniques and using your phone and having everything in the cloud and so forth has raised privacy issues and possibilities of harm, if you do not have a benign government, shall we say, or what do you think about that?
I work in the Center for Technology and Behavioral Health, and that's been, I guess, for 10 years or so now. And so we have these discussions and speakers about this issue, over the years. And, patients, people interested in working on their issues have concerns about privacy. Some have none, some have a lot, and some people are in the middle. And, depending on what you're disclosing, if it's cannabis, right now cannabis is legal, in most states. And so you'd think it shouldn't be an issue. But, cannabis can still have some, if it's THC-laden cannabis, it can still have some negative effects, and employers might want to know, or insurance companies might want to know. And, you can imagine all the things that could happen. And so you do your best. And you have all kinds of safeguard systems on the whole application and the program. They are fairly secure, but people can hack almost anything if they're really interested in it. And so there has to be at least some leap of trust for people to get involved. How many people really exclude themselves? It's hard to know, but certainly you have a good number when you run a study, even if it's not a treatment study, that are hesitant to engage in these kind of things.
Yeah. Again, it's not unique to what we're talking about. I mean, it's all of the issues about, electronic medical records can raise these issues, I guess. Yeah.
But interestingly, it makes me think, in the digital health world and the application of it, more and more studies are looking to just passively assess people's records, and not as a negative thing, but as a way to detect that they're having problems, that they're at risk. As you can passively look at somebody's phone records, Facebook records, EMR data, et cetera, and identify people that are at risk and offer them digital interventions. So theoretically, that sounds great, and you could reach more people and help them before they get too far down the road. But on the other hand, you've got that security and privacy issue that is paramount. So it's a very tricky area of research right now.
So far, we've been talking about interventions aimed at reducing frequency or amount of use of cannabis. But another important aspect, of course, related aspect, is this phenomenon of craving, right? And I know you've done some work on mobile interventions for cannabis craving as well. Before you tell us about the work, can you define craving for our audience? Then I can ask you about how that's measured and whether there's anything different about addressing that phenomenon versus what we've been talking about already.
Yeah, define craving. I'm probably not the best person for this. I'll obviously deal with craving, et cetera, but I'm not the biggest fan of it being a primary target all the time that we're really going to try to get at. Basically, craving is an urge, a desire, a want, or a compulsion to do something. And in this case, cannabis. So you're sitting around something, you go somewhere, and all of a sudden you just feel like, I feel like using, I want to, I feel like getting high, whatever. So that's a craving. It's an urge. We all have urges and desires, and they sometimes come out of nowhere. They're triggered by certain things. And people have measured that in the substance use field with single items. How strong an urge do you get? How strong of a desire? But there's also been a number of different measures that have like 17 items or 19 items. Sometimes they have 4 separate subscales for kind of pieces of the craving complex, etc. So, the way I think of cravings is, they're important to deal with. I'm pretty much a behavioral guy. And so if people are telling you they're craving, and when they get these cravings, they just can't help themselves, or they really want, you have to deal with it if that's, you're trying to help them. And so a craving is something people identify that happens before they use. And so it gives you a target of something to work on. So if they say, I crave when I come home from work, or I crave the first thing I get up in the morning, you've got something to work on. You've got to figure out how to help them get through that morning, quote, craving, or that morning time, whether there's a craving or not. They got to get through the morning because they always tend to use then. Or whenever they go to Tom's house, they always use, because as soon as they walk in, man, they're ready. So it's a good way to identify where you need to help somebody and when you need to help somebody.
And I know that one of the techniques you've used is this thing called ecological momentary assessment. Can you tell us what that is and how that works with these digital interventions?
Yeah. So before I go there, just, you say I have. Most of this work is very recent, and it's mostly other people's work. And I've been the old cannabis guy that helps them with it. But for example, the mobile craving work was an idea of a postdoc of ours, Molly Anderson, and my colleague, Catherine Stanger. And they were looking into this using a cool methodology called a micro-randomized trial. And cannabis was a good target behavior because Dr. Stanger and I have worked on cannabis projects for adolescents for a long time, and they complain about cravings. And so we're in the digital center. And so what they came up with was plenty of people, when you do a therapy session, people identify their cravings. You think of, all right, let's talk about how you're going to deal with this tomorrow morning, and you come up with a strategy, et cetera, et cetera. But what this ecological momentary assessment strategy allows you to start to do is, can you detect when they're having cravings in real time?
Mm-hmm.
Carrying around their phone, this study in particular that you're talking about, they got pinged. Their phone rang, got pinged, didn't ring, but they get a notice on their phone 3 times. I think it was 3 times a day, and they ask them if they've had any craving. They get a little digital question. Did you have any cravings since the last time you were pinged? And if they said yes, they automatically got randomly assigned to either a mindfulness intervention for craving, or a distraction intervention, or just thank you for letting us know. And so this EMA allows you to start to assess people more frequently while they're home and in and about in the world. And so that's cool just in itself. You learn more about how things work and closer to real time and in the real world. But some of the purpose of the EMA in this strategy is to eventually develop something called an ecological momentary intervention, or a JEDI, which is a just-in-time intervention. So what you can eventually do is kind of like what I was saying. If you start to detect when people have cravings, and so whenever they're having a craving, they'll start to get a ping at the same time every day, and that triggers them to do something in particular on their phone, or something they're supposed to do when they get the ping that could help them cope with the craving. You've now developed an intervention that's tied to these assessments that you've learned, where you've learned all about when things happen. And so in this case, like I said, we're looking at a mindfulness strategy versus a distraction strategy, because the literature has kind of shown that at least for alcohol and nicotine, mindfulness can help with cravings, and distraction is always a pretty straightforward thing you teach people as a possible way to deal with cravings when they come up when you do regular therapy sessions.
Certainly something you do with young kids, and also people with dementia, maybe, where works across the spectrum.
All of us can use the pings all the time. And that's what's so exciting about some of this digital stuff. We'll be able to get to them right where they are, when they are. They do still have to answer their phone, or respond, or look at their phone. They do have to do what they're supposed to do. So there's still all the adherence things, but you're a little more they're a little more in their face and in their real time, that it's probably more likely you're going to get to them. Now, in this case, this study that you're referring to, neither intervention did much. These were young adults craving, and it didn't really seem to reduce cravings much more when you looked at how were they craving the next time you pinged them or not. But it was kind of a demonstration of things you could do and try to do, and that are now possible to do using digital technology.
Maybe you need to engage the influencers to engage these folks.
Yeah, well, we can talk about that later. I think that's one of the areas you wanted to get into.
Yeah. Okay. So thanks for talking about that. Another area I know that you have done some work in is coming back to sort of cannabis and also medicinal cannabis, is discussions in the healthcare setting about cannabis use, whether it's medical or recreational. And, how good are doctors and other providers in doing this? How can we improve that communication? Can you talk a little bit about the work you've done in that area?
Yeah. I haven't done a lot of research in that area myself, but I've done a lot of consultation and guideline writing with local providers. And that I assume you've had this longer than me, given you're in California. But since the onslaught of medicinal cannabis possibilities and legalization, physicians have been, and healthcare workers generally, are put in a tough position. People are coming in asking them for cannabis. They have to write their approval out so they can go get cannabis in the dispensary. And one, they know nothing about it. Two, what they do know about it usually is cannabis is a drug that people use to get high. And what do I do? From what I know, there's potentially bad side effects, et cetera. So physicians keep coming and coming saying, what do we do? And healthcare organizations don't want to turn these patients away because it's a loss of business. So if someone comes to you and say, I'd really like to try cannabis for my chronic pain, and you say, no, I don't think that's a good idea, they're going to go somewhere else and try it. At least some of them are. And so they want to figure out these patients that they've been dealing with for a long time, and what do they do in these situations? And so at Dartmouth, we had a little group that got together and tried to come up with some guidelines for what physicians can do, how to assess it, what kind of recommendations to try to make, et cetera, how to be responsible in face of not having that much knowledge. Now, it turns out, I guess, forget exactly why, but a postdoc that we recently had, she's now Kara Struble, she's now at the University of Maine. She was mentoring some undergrads at Dartmouth. And this one young student who's wants to go to med school, he was helping us out with our different cannabis projects. And for his own project, he wanted to survey people about their interactions with their provider. And so we thought, well, there's not a lot out there. There's probably 3 studies we could find about what goes on in the healthcare provider patient interaction. And so he developed a survey we did together, and he recruited like about 500 cannabis consumers and had this detailed survey about their initial interaction with the clinical provider when they sought medical cannabis. Just as we expected, I think the long and the short of the findings was that less than half of the patients, and they saw like 4 different kinds of providers. We tried to categorize the types of providers, but I think less than half of the patients had any discussion of risks or even had a follow-up appointment after that one to see how things were going with their medical cannabis. Less than a quarter, and I think it was between about 10 and 25% across the 4 types of providers, offered any recommendations about product, dose, method of administration, where to get their cannabis. And very few people, I think less than 45% or 40%, offered any information about risk mitigation. So how to make sure you don't get yourself in trouble or watch out for these side effects. It's kind of like, what did you expect? They don't really know what to say, and we don't really have the answers, but we need to come up with some type of education for providers. So one, they feel like they're being ethically responsible and being responsible clinically. And so what should that education look like? Sometimes you'll read the end of an article, it says healthcare workers need more education on medical cannabis and how well it works for chronic pain or whatever the disorder might be. But it's a very tricky literature to read, and it's very nuanced. There's no discrete guidelines of dose or anything for any of these problems. It's written anywhere in black and white. And so I've been interested in a long time and haven't done a lot about it, but trying to figure out how we can help the healthcare system deal with patients and provide at least some advice, recommendations, risk mitigation to help people manage the medical cannabis system. Because at least in where I live, whether it's Vermont or New Hampshire, you just get approval and then you go to the store and you have to pick your own product and you have to pick your own amount, and there's just no guidance on that. And so you could get yourself a gummy, you could get yourself some high potency buds, you could get some oil. When should you take it? There's just no evidence and no guidelines. And so they're kind of at the mercy of the people working at the shop or what they read online. And, if you go to just the right place, you can find some good stuff online, but, it's a little bit scary.
Yeah, I know that. I mean, you're also talking about states that have a medical marijuana law, but maybe not fully recreational legal, right? Because in fully recreational legal places, people just can go to a dispensary. They don't need a doctor to recommend. Nevertheless, I think the point is it would be great if physicians were able to discuss these things, knowing that they're going to have a certain proportion of their patients using cannabis, whether it's medicinally or recreationally, and to give them evidence-based information, at least as good as we can have it at the time.
Yeah, and you hope if it's a disorder that they're currently being treated for, that not successfully, obviously, which is why they're looking for something else, that they go to the person they're being treated, so they have the history and some background knowledge to try to make the best decision if they're really going to try cannabis and how it may or may not interact with other substances and all those kind of things. Yeah, so we're nowhere near that. I'm sure there's some good healthcare workers out there that really know about cannabis, but it's few and far between that could, I think, provide good recommendations and risk mitigation.
It's interesting, actually, in California, which has been in this business much longer than a lot of states, at least the medical part. The Medical Board of California they worked with us to develop some kind of a decision tree. Let's say a patient comes to you and they say, I have this kind of pain and so forth, to go through a protocol that looks at, of course, what kind of pain it is and so forth, but then what kinds of treatments have been tried, were they successful or not, and gradually you branch your way down to whether medicinal cannabis might be recommended for this person based on the condition, the history, and so on and so forth. So there's been some efforts in that regard, and they're not perfect, but
yeah. So anyway, that's been the interest in it. It's I'm sure we'll continue to move forward and get better guidelines and things out there. But it'd be nice if we at least had the risk mitigation thing down and help people. Canada has some general guidelines that are pretty common sense and good. At least if you follow those, you'll help reduce the risk, which is a good place to start. But if people are going to have a shot at it helping, it'd be nice to, to have some better guidance like that. The tree starts with whether or not it should be medical cannabis. And then the next tree is like, well, how much and which type? And that's the kind of next part of that
right.
Tree. Yeah.
Yeah. We actually had Dr. Mark Ware on one of our earlier podcasts, and he was, I think, very informative about the Canadian experience. Of course, we joke that the US, we're such an exceptional country. We don't care to learn from anybody else, including the Canadians, but hopefully somehow.
If you're fortunate enough to go to Mark, you'll have a good chance of getting the right thing and the right dose, at least something that has a chance. But there aren't a lot of Marks.
Yeah. So just moving on, one other area I wanted us to touch on is that, you've been interested also in the co-occurrence of mood problems, for example, depression and problematic cannabis use. Are there modifications of the interventions you've been talking about in those circumstances?
Yeah. Just generally, I guess if you're going to try to integrate depression with cannabis as two targets, reduction of cannabis use, reduction of depression, I mean, simply it's kind of integrating the two.
Well, can I just interrupt for a second? Do you find that it's sort of common for mood disorders and, say, problematic cannabis use to go together? Is there an overlap there?
Yeah, there's definitely an overlap. There's a co-occurring, it's up to 50%, not with just depression, but with depression or anxiety or PTSD. 50% of the people that come through the door that are having problems with cannabis are having another type of psychiatric issue. Typically, they are, in a sense, think it helps somewhat, but they'll also tell you that it probably doesn't help. They're worried it's making it worse, but they feel like that's what they use to cope. And so it is their coping mechanism, perhaps, for their other psychiatric problem, but they also, in some regards, tell you how it's making it worse, which, that's kind of the nuance of it all. And so you definitely have this co-occurring thing going on. And So that's true of all substance use disorders. And so over the years, even the basic treatment, basic cognitive behavioral package for any substance use disorder has mood management modules in it. So there's always at least an option and a good, written out 2 or 3 sessions on how to help people with mood management. Because when you talk to your patients, they're always tying, and you look to say, well, what's your trigger for cannabis? When do you use more? When do you use less? All that mood always comes in there. So helping them with mood management so that maybe they can manage their mood through other ways other than use of cannabis makes sense, or alcohol, whatever. And so when you're trying to combine the two, it's in a sense not simple, but it's a straightforward integration where you're talking, have some educational things about how the two go together. But generally, you're trying to merge what we know about treating depression with what we know about trying to quit cannabis and making them work. Back in like 2009 or so, Francis K. Lampkin from Australia put together a computer-driven package, kind of like the computer-driven package that I was talking about that we did. But hers was for depression, alcohol, or cannabis use. So it was you'd sit down at the computer and you'd work on your modules for depression and cannabis or alcohol, whichever it might be. And she found pretty much the same kind of things that we found, that the computer could generally do about as good as the therapist, if not maybe a little bit better. But it was a way, again, to get more people in and have a way to make sure they get these good cognitive behavioral skills. More recently, in our lab, well, not my lab, but in our shop, another postdoc working with Nick Jacobson, postdoc was Amanda Collins. She was interested in doing an EMA study like we talked about before, in momentary assessment, where she wanted to look at depression symptoms throughout the day by pinging them 3 or 4 times a day, I think, and also how it related to their cannabis use and amount of cannabis use. When they said they were depressed in the morning, was there more cannabis use in the afternoon? Vice versa, and when they're depressed, when they're using cannabis, are they more depressed? You're trying to kind of tease that all apart. And that's kind of like the holy grail. Does cannabis come first? Does depression come first? Which is driving which? I think the simple answer is they both drive each other, and teasing it apart, I'm not sure if we're ever going to get there. But she had some interesting findings where she could see, in some ways cannabis was pushing depression, and in other ways depression was pushing cannabis. But it was a first study, and I think helped us realize how much further we have to go, where other than just saying, oh, you're depressed and use cannabis, here's a depression and cannabis package. How can we tailor this even better for you? How does your mood relate to cannabis? And if you have set up one of these EMA systems, you can have it at the individual level, if you think about it, how it's working in regard to that person. So for that person, it might be one direction. For another person, it's another direction. And it might be certain times a day it's worse than others. And so you would put it in like a depression intervention in the evening for somebody versus somebody. You can see the different ways you can try to tie those together. So that's the long goal for those kind of things. But as we are more able to do things in real time with these EMAs, or nowadays also just with sensing on your phone can tell how much activity you're doing, and do passive sensing. You can pick up things that are related to depression or cannabis use. You can start to tailor things to the individual more so than we've been able to do in the past. And we think that's going to be better outcomes. Will it be or not? Who knows? But that's where we're trying to move in that field.
Well, it sounds, though, that it's very important to recognize that these are complex and multifactorial conditions. Obviously, a couple of the reasons people start going into mind-altering drugs, if we can call them that, is, well, A, maybe curiosity, and then it may help with certain things like sociability, whatever it may be. But the other is that it may actually help the person deal with something more painful like depression. And then, of course, then things can spin out of control after a while.
Yeah, that's, I always try to remind people in most of my talks, this is, you're expressing empathy, right? So you have to have empathy. Why are people doing cannabis for depression when we don't have any idea that it really, quote, works? There's no efficacy of it for anxiety. Well, that's because they're depressed and whatever they've tried isn't working, and they're shooting for something else. And cannabis, works well on symptom reduction. I mean, most drugs do. So whether it's anxiety, depression, etc., if you use cannabis, you're going to feel differently. It's mind altering. And so you feel a little better, you feel more relaxed. It might be momentary. And like you said, it might eventually not facilitate a long term recovery. But in the moment, it provides some relief. And relief is what most of us are looking for when whatever we're trying before isn't working. And unfortunately, medicine is good out there, but it doesn't help for a lot of things, or it doesn't help a lot of people. It doesn't help everybody. And so people are struggling. And cannabis, like alcohol or other drugs, can help you change your mood, feel a little better for a while.
Well, we're kind of moving, I think, toward the end of our time. And maybe I could ask you, wrapping it up, do you have further thoughts either on the use of social media to engage both recreational and medicinal cannabis audiences as well as their providers? Is there anything that you're thinking about for the future? I asked Mark Ware, the Canadian, if you were king, what would you do? And he, in a cheeky way, responded. He said, "I thought you had a king."
You're trying to take me there again, but I'm going to stay pat here and try to take the question.
There you go.
Social media, social media is influencing everybody. And you used the term influencer before. And certainly I've been involved with some projects. I can't really think what they are, where we really thought we needed to engage some influencers to try to get people to really take hold and look at this, quote, positive side of things that we're trying to develop. But the reality of what's going on right now, I think, is the cannabis world is a big cannabis industry. And it's a for-profit industry that's out there. And for-profit means they want to make money and they want to sell their products. And social media is the way to touch people, and everybody sees it. And so they're out there trying to influence, advertise, whatever it might be, make more interesting products, show them online, and get people to use more cannabis products, which isn't necessarily awful, but the people that have potential for harm, that's kind of what's happening. And sometimes they target vulnerable people that we know they shouldn't be targeting. But it's like any other commodity. They're trying to figure out how to increase their market. So you can't, quote, blame them for that. But on the other side, you could use social media, to put out better prevention messages, more information about what we really know about certain types of products, what are safe products, what aren't so safe if you try. But it all costs money and time, and we don't have anybody thoroughly invested in so much to counter the influence of the industry. And it's a harder thing to do because I've spent my career, I'm the negative cannabis guy, right? I'm always trying to have treatments for it, meaning it's a problem, right? But alcohol is a problem. It doesn't mean that you can't use cannabis and it can't be fine recreationally. It might help you with something or other, right? I have no problems with that at all. Never have. But as soon as you're somebody that's trying to treat cannabis use disorder, you're the bad guy in the cannabis world. And so I've always tried to have the middle ground and make sure people don't see it that way. I'm trying to help people that have problems, not make cannabis users stop that are doing just fine. They want to use cannabis, that's just fine. But to get the message out that's nuanced and trying to convey how it potentially could be helpful, but this is all we know. And if you want to do it, it's kind of it's a long dialogue. And so it's not an easy soundbite. The easy sound bites are the, quote, the very anti-cannabis. It could fry your brain and all that stuff. That doesn't work. So yeah, what would the soundbite be that you could put on social media? Or could you get some influencers to somehow, convey things to folks? I don't have the answer, but that's how, that's what I've been thinking about for a long time. It's just hard to get the nuanced message out in a way that people will listen.
Yeah. And also, I think sometimes, I don't know how you feel about it, we also may not overvalue, but maybe overemphasize the impacts of these messagings. I'm thinking, actually, my colleague Jamie has been doing some analysis of experience in California with, what kind of change has there been in the amount of cannabis use or people who use it and so forth before and after legalization. And actually, can't find much difference except among old people who are, want to work on their arthritis or something like that. So there's always those issues, I think. How much impact can we actually have? I'm not saying social media or advertising doesn't have an impact. Obviously, it does. It's $1 billion industry, but
yeah, I think, and I don't know what data you're collecting. The data I think the national data are sort of the same. There's not an overall increase since things have been going on. There is more daily use. I think some people that were already using, now it's more easily accessible. You don't have to worry about legal things. I think they've ramped it up a little. You don't go days without it because you can get it down the road. But, it looks like the very young people, it's slowed down. And I'm always hopeful that as we legalize, and that's what I always thought would happen, we could actually do a better job of prevention. You could actually talk about it as a substance rather than just something that's awful. And then kids will listen and maybe.
Well, it's maybe less novel, and the old forbidden fruit theory.
Yeah. Again, what I worry about, my main concern is people that are vulnerable. So people that do have primarily different types of psychiatric disorders, that it helps them feel better, but in the long run, it's probably a negative thing for their long-term outcomes. But it's most attractive to them because getting back to the principles of reinforcement, one, if you do cannabis, you get high, and most people like that. And so it's reinforcing. You're going to do it again because you like the effect. If you're also depressed, it helps relieve your depression temporarily and you'll like the effect. And it's kind of like a double whammy. So people that have a condition that cannabis can provide a little relief for, they not only get the effect that if you don't have it that you sort of like, they also get some relief. So it's kind of a double. And so they're more likely to do it even more. And, more isn't better usually. It's probably, moderation is key, but I'm afraid it can lead to more. So anyway, that's probably my primary concern about those kind of things.
Well, excellent. Well, Alan, thank you so much for taking the time and joining us in this podcast. Very interesting things. I'm sure our audience has learned also something about things like contingency management and ecological momentary assessment, all of these things that roll out of our tongues but are hard to talk about. Anyway, my guest today has been Professor Alan Budney from Dartmouth. Thank you for being with us today.
If you like this podcast, please subscribe so you don't miss future episodes. For more information on the Center for Medicinal Cannabis Research at UC San Diego, please find us on social media at CMCR_UCSD on Twitter or X, Instagram, and other social media platforms. Or visit our website at cmcr.ucsd.edu. Thanks for listening.